Hello, my name's Professor Finlay Macrae. I'm a Professor of Medicine at the University Department of Medicine and a gastroenterologist who's worked for a long time and closely with the Familial Cancer Centre, the Parkville Familial Cancer Centre. I'd like to acknowledge the support and funding from the Cancer Council of Victoria for this webinar and their wonderful work they do in the prevention of bowel cancer and other cancers that are part of our community. So my talk today is on family ties, identifying and managing hereditary colorectal cancer risk. The learning outcomes from this webinar are to identify appropriate patients for referral to familial cancer centres and to understand how to construct a pedigree or family history relevant to familial cancer. And you'll also learn from how to implement potential medical prevention options for high-risk patients. So first of all, pedigree construction. This pedigree shows an autosomal dominant pattern of inheritance that moves between one generation and another, with the phenotype of cancers appearing across the generations. In this case, colorectal cancer and endometrial cancer in particular, and for the purposes of the syndromes we're talking about, the early age of onset is a particular feature. So this is an autosomal dominant pattern. Males are in squares and females circles, and where the logos are crossed, that means the patient has died. An autosomal recessive condition shows the phenotype developing laterally across a sibship rather than across generations, and that would be the clue to suggest an autosomal recessive form of inheritance. Here, of course, it's not depicting males and females, it's depicting a neutral gender. So when we talk about cancer genetics, we have to think about high-risk genes, moderate-risk genes, and then single nucleotide polymorphisms, or SNPs. So the high-risk genes are the ones we're going to be talking about mostly. They have a high penetrance for the development of cancers, and in terms of our talk today, colorectal cancer in particular. And some of them are autosomal dominant and some of them are recessive. The ones responsible for Lynch syndrome are highlighted in bold. You can see there on the right. But you can see there is quite a range in blue of the high-risk genes that we manage in the familial cancer clinics, and some moderate risk genes, and some that provide only small risk, but still, particularly when accumulated as a number of SNPs, represent a risk profile as well, and that is becoming more and more part of our understanding of risk as we learn more about single nucleotide polymorphisms and their relationship to risk for cancer. Single nucleotide polymorphisms are more common in the community, although of low risk, whereas the high-risk genes are really quite rare, but very important in terms of their penetrance for the development of cancer. So turning to Lynch syndrome, once called hereditary non-polyposis colorectal cancer, a terrible name, hereditary non-polyposis colorectal cancer. This is an autosomal dominant condition due to deficiency in mismatch repair genes. It's quite common. 1 in 289 people in Australia carry a mutation responsible for this condition, and it leads to a range of cancers, of which colorectal and endometrial is by far the commonest, but there's also a tail of other genes which are more common in carriers than in the general population. You can see them listed there, many different types of cancers, although notably not lung cancer, and uncommonly and perhaps not breast cancer. The syndrome is characterised, as I said, by early age of onset, and notably the cancers that occur, particularly bowel cancers, have a particular molecular phenotype which is quite easily demonstrable by molecular techniques, where microsatellites are unstable and repetitive in nature, which is a signal that can be quite easily detected molecularly and a signal also that if present, the clinicians should be thinking about the possibility of Lynch syndrome. So the mismatch repair genes are responsible for correcting mismatches that occur by chance in the lining of the colon or other organs, which occurs quite commonly, in particular in the colon quite commonly. The colonic epithelial cells turn over every 3 or 4 days and reproduce themselves. So there's a lot of replication of DNA occurring all the time in the colon, and with the vast number of cells there, there's a real finite chance that there's an error made in the copying process, perhaps through to environmental exposure. And we have these housekeeping genes called mismatch repair genes, which transcribe into enzymes and proteins which, first of all, identify the error that's being made through mismatch recognition, and then excise the error that's been made in the daughter cell from the replication, and finally pass it on to polymerases which insert the correct sequence. So these mismatch repair proteins are working all the time to protect us from the random errors that occur through the very frequent replication processes that are occurring in all of our body, but particularly in the colon because of its rapid turnover. We used to think that we would be best able to identify Lynch syndrome by looking at family histories and applying what I've always called the 3-2-1 rule. And this is still a very important family history tool to lead us to the possibility of Lynch syndrome. So if we have 3 relatives with a Lynch syndrome cancer, and you will have seen those cancers in the previous slides, over 2 successive generations, here we see the autosomal dominant pattern, with one related to the other 2 in first degree, so it's a cluster of these 3 relatives, and at least one diagnosed under the age of 50, that's the Amsterdam criteria. And if you have that, then you've got at least a 50% chance of finding Lynch syndrome through appropriate germline testing as responsible for the cancers occurring. This, of course, is in the absence of familial adenomatous polyposis, and we like to think that the cancers are verified across the family to enable that 3-2-1 rule to be applied. And you can see the range of cancers, some of the more common ones on the bottom, but the others I mentioned before. These days, however, we broaden our approach to identifying Lynch syndrome, and in particular the third dot point there is the one that we focus on particular. So anybody with a cancer under the age of 60, and indeed contemporarily in pathology practice of any age, should have this molecular phenotype looked for in their colorectal cancer, or an equivalent test, which is immunohistochemistry, for the expression of those mismatch repair proteins in the tumour. And if they turn up with a pattern of loss of function, of usually coming in pairs like MLH1 and PMS2 and MSH2 and MSH6, that's usually the lost patterns that one sees, then the hunt is on in those patients for the possibility of Lynch syndrome. It doesn't always occur because, in fact, that pattern also occurs in about 15% of sporadic cancers, but indeed about a third or a little under a third of the patients that have that MSI high pathology will have Lynch syndrome, and it's very rarely, if ever, found without that phenotype of microsatellite instability. So it's a very strong tool or signature to lead us to finding Lynch syndrome, which can initiate, of course, a progression of searching for the mutation across the family. So any cancer, in fact, that has microsatellite instability in this sense should be considered for Lynch syndrome. The other markers would be metachronous or multiple colorectal cancers occurring synchronously or metachronously, or indeed multiple HNPCC cancers, Lynch syndrome cancers, not just bowel cancer, leading to this suspicion. The other ones we don't rely on so much because the microsatellite unstable phenotype is so useful for us to find the condition. Here's the immunohistochemical pattern, and it's demonstrating in this case the loss of MLH1 in the top left-hand corner and PMS2 in the bottom right-hand corner, whereas the other proteins, MSH6 and MSH2, are expressed there. You can see them brown, but there's no brown in the MLH1 and PMS2, indicating loss of those proteins, and therefore a tumour lacking expression in MLH1 and PMS2, which is the characteristic finding, as it happens, for a germline mutation in MLH1. That would be a patient that we would be exploring considerably to see whether they have Lynch syndrome or whether they fit into the group of sporadic loss of those markers in the tumour, which represent, actually about 2/3 of the cases who present with that particular pattern. The younger the patient is, the more likely it is that it's going to be Lynch syndrome. Now, I think it's important to understand the decades-old now hypothesis that was put forward by Knudsen, which is the 2-hit hypothesis. It's quite simple to think of. Here we have the concept that a patient has a mutation from birth in, say, their MLH1 gene. So on one allele, and we all have 2 alleles, one from our mother and one from our father. So on one allele, that MLH1 gene is mutated and not working properly. And so if you go down to the offspring, and this actually would apply to the parent as well, a second event occurs out in the colon at some point in time and knocks out the equivalent good MLH1 protein that's emanated from the mother, leading to a second hit in the tumour peripherally, the first one inherited in every cell in the body, and the second one just been acquired as a somatic hit sporadically at some point in time in the life of the individual, knocking out the second allele and therefore all function of that MLH1 gene. This depiction is, the second hit is depicted as a loss of heterozygosity or a deletion of a part or all of that MLH1 gene, incapacitating that allele, which then would lead to total loss of capacity to function of the MLH1 gene in that cancer, and hence the accumulation of mutations leading to the unstable microsatellite unstable cancer. So the Knudsen second hit hypothesis is widely applied in cancer genetics. Now, you're maybe seeing not the internal colonoscopic findings of patients with Lynch syndrome, but you may well see some other features. And here is a skin feature associated with Lynch syndrome, which goes under the name of Muir-Torre syndrome. Here, cutaneous manifestations, sebaceous adenomas, keratoacanthomas, or sebaceous carcinomas. They can also be tested by the immunohistochemical technique to look for the loss of expression. And if that's there, then there is a chance, as it happens not as high as if it was in the colon, that that patient has Lynch syndrome as well. And this is a skin manifestation of the condition. So we get a whole stream of patients referred from dermatologists and general practitioners with sebaceous adenomas, keratoacanthomas, or sebaceous carcinomas. And the younger they are, the more likely we would be chasing the possibility of Lynch syndrome as causing this. So there are some interesting other features about Lynch syndrome, which I'll just mention. Firstly, we've moved from the position of, say, the Amsterdam criteria as the screening process through to testing every colorectal cancer, which I've mentioned. And it's also been established about a decade ago that this whole process of identifying Lynch syndrome is very cost effective in the healthcare system, particularly if it leads to identification of other carriers through testing other family members and preventing the development of cancers in those other family members, because every time a cancer is diagnosed, there's a real cost to the community. And if you can prevent it, then the cost-benefit analyses are very strongly in favour of identifying Lynch syndrome across the community, putting them under surveillance, identifying preclinical lesions and preventing their cancers developing. It depends a bit on how many relatives are identified, but it only takes about 2 or 3 relatives from the index case to be identified and indeed we have a strong cost-benefit case. You can use the immunohistochemical technique also to look for loss of mismatch repair function in other cancers. And another point is that the cancers in Lynch syndrome generally have a better prognosis than sporadic cancers. Metastases are less likely, and the immune system is quite active in trying to control and maybe even eliminate the cancers that occur in Lynch syndrome for reasons that I can't go into just now. So they often survive their first cancers and are alive to get their second and third cancers, which we have to be wary of. There are techniques that we can fairly easily differentiate the sporadic microsatellite unstable cancers from Lynch syndrome. That is by testing the promoter of the MLH1 gene for methylation, or doing tests called BRAF tests, and that will separate out the Lynch syndrome from the other sporadic microsatellite unstable cancers. The other points to note are, and we're moving perhaps to using the tumours themselves to identify Lynch syndrome rather than a blood test, which is still used mostly to identify the inheritable germline mutation that's responsible for Lynch syndrome. There are some other rare genes that can cause microsatellite instability, and they're also inheritable in an autosomal dominant fashion. I want to talk briefly about penetrance, because that's the risk of getting bowel cancer if you're carrying one of these genes. Here you can see across the top the 4 main genes responsible for Lynch syndrome, and down the left-hand side you can see the most common cancers that occur in Lynch syndrome, and the percentages give you the average penetrance or risk for getting those cancers during the lifetime of individuals. And you can see from colorectal cancer it can be up to 50% lifetime risk for an MSH2 carrier, with the less penetrant genes such as the PMS2 gene dropping below 20%. And you can see that in females, particularly the MSH6 carriers, have a substantial risk of endometrial cancer, as do MSH2 carriers. So we have to be also very wary of endometrial cancer in all those top 3, MLH1, MSH2 and MSH6. Much less penetrant and less risky is the PMS2 gene. I think this is a great tool that everybody has access through the web, which you can get through www.plsd.eu, which stands for Prospective Lynch Syndrome Database.eu. And you can sit there in your general practice, call this up on your computer. This is the screen that will come up when you click on that website. And you can see it's an interactive website. You can type in what cancer you're interested in, or any cancer. You can type in the gene, and of course this would be at a point in time when the particular gene in a family has been identified. Then if you've got a 25-year-old woman in front of you, you can click on 25, and as a female, if you do that, click on all those, and then you press go, and what it presents is the penetrance for, in this case, any cancers occurring in a 25-year-old female aged 25 who's carrying a MLH1 carrier, MLH1 mutation. And you can see by the age of 70 that their risk of getting any cancer is about 75%. And you can click on the other specific cancers and it will produce graphs like that depicting the risk for any of the cancer. Very useful counselling tool, and very well substantiated by good data, including ours from the Royal Melbourne Hospital. It's a program that's run by my colleagues in Norway. So when we identify a patient, say with an MLH1 with a microsatellite unstable cancer, or indeed any of the other risk features which I'll mention, we have at our disposal panels now of genes that we can apply to test the person for the possibility of a germline change being found through a blood test. If the patient's got an MSI high cancer or a microsatellite unstable cancer, we're looking particularly at the Lynch syndrome genes, MLH1, MSH2, MSH6 and PMS2, but these all come now in panels, so we don't just order one gene, we order a panel, because the cost difference between ordering one gene and here about a dozen genes is negligible. It's about $50 difference between 1 and 12. So we approach this by testing with panels, and we will choose the panel which is most appropriate to the circumstances. So if there's lots of polyps, if this is a polyposis condition and we're not seeing microsatellite instability, we'd be going for the polyp panel. If there's other cancers, such as ovarian cancer in the pedigree, then we might use that second ovarian and colorectal cancer. If we're really not sure and it's scattered across a whole range of different cancers, then we can go for the biggest panels ranging from 27 to 72 genes at one shot. And you can see the costs are not really too bad, particularly when you put it in the context of, say, having to do one colonoscopy for a patient, which currently is about $2,500. So these are not really expensive tests when you consider the benefit that applies not only to the individual but to the family in terms of their planning and surveillance. I'll just skip over that and move to the difficulties in interpreting the DNA sequence. It's not straightforward, and I'll just touch on this because this is a major part of my research activities internationally and at the Royal Melbourne. When a DNA sequence emerges from a sequence, the sequence can either be clearly damaging, such as a truncating mutation in the gene, and we're quite comfortable saying this is a pathogenic mutation. There could be no variation identified that's different from the normal reference sequence. It could be a variant that is not seen as in the normal reference sequence, but is also not pathogenic, not clearly pathogenic. We call those variants of uncertain significance. So they're not totally normal, but we can't pin them necessarily as being damaging. They're a real pain to us in clinical practice because we can't tell the family that they're off the hook. In other words, we haven't found anything, but we also can't tell them that it's definitely pathogenic. So a lot of work goes in locally, nationally and internationally to try and interpret a DNA sequence that's uncertain. And we use different sets of information to reach a conclusion, ranging not only from the sequence itself, but also looking at any family history and how the cancers segregate with a particular genetic change across a family, not only locally, but also nationally and internationally. We now have international outreaches that will reach out across the world to see what has been experienced in this sort of space. We can look also at the association of the tumour features, such as immunohistochemical loss with the variant, and come up with a conclusion. We can see whether that particular variant is very common in the community, and the more common it is in the community, the less likely it is to be damaging. Otherwise, we'd see a whole lot of damaged pedigrees in the community. And we can have a look at some other subtle things, including experimental processes such as introducing sequences into yeast to see whether they disrupt the function of the gene experimentally. So all of those can be computed together and come up with a conclusion as to whether it's damaging. That's quite, to me, exciting work, but helps enormously in counselling once we come to a conclusion. So I just want to finish with some recommendations about how we manage Lynch syndrome. We generally start screening at 25 for MLH1 and MSH2, and a little later at 35 for MSH6 and PMS2. The frequency is every 1 to 2 years colonoscopies, and of course we'd be looking out for skin tumours. And for endometrial cancer, we haven't got any good screening techniques. We're alert to the need to do prophylactic surgery after completion of family, usually between 35 and 44, where prophylactic hysterectomy and or oophorectomy is done in Lynch syndrome. So screening for other tumours other than colorectal cancer is not very good, and we don't undertake it because the screening techniques are poor. Gastric cancer may be an exception, but gastric cancer is not that common, and we're not all that good at detecting early gastric cancer. So there's a difference of opinion as to whether gastric cancer needs to be screened for within Lynch syndrome. At the Royal Melbourne, we actually don't screen for it, although at Peter Mac they usually do. Now I want to mention aspirin. Aspirin is a bit of a wonder drug. The CAP2 studies that we were very much involved with were published some years ago. This was a randomised controlled trial in Lynch syndrome where carriers were
randomised to either 600 milligrams or placebo, and then they were they were watched for their colonoscopes. This was an international study. We had quite a big contribution from Australia in terms of contributing. And what it found was that the incidence of colorectal cancer was significantly reduced by about 60% by about 9 years, with the difference appearing at about 4 years. So the graphs separated. On the top you can see the placebo in blue, and underneath it the aspirin in red. Those were the colorectal cancers, and that's an intention to treat analysis on the left and a per protocol analysis on the right. So there's a latent period before the protection appears of about 4 to 5 years, and it continues right up to indeed 20 years. There's still this separation in cancer from simply the exhibition of aspirin at 600 milligrams for 2 to 5 years. And indeed the same thing is seen with all Lynch syndrome cancers, including endometrial and other cancers, at significant levels, although not quite as strong as it is with colorectal cancer. CAP3 is about to be published in about a few weeks, and it's looking at whether 100 milligrams does the same job, and the short message is that it does. So you don't need 600 milligrams, you only need 100 milligrams to get the same benefit of protection against cancer. Moving on quickly to familial adenomatous polyposis, you can see a colon there with the characteristic phenotype of polyps. Here's some other features of FAP, not only in the stomach on the top left, and the colon in the middle, the ampulla in the top right. They get teeth abnormalities, missing teeth, you can see there, and these curious congenital hypertrophy of pigment epithelium, which is not clinically doesn't cause a clinical problem, but is a marker of FAP, and desmoid tumours occur in many parts, including here on the back. So here we screen for the condition in children aged 12 to 14, and this of course would be where it's elsewhere in the family. We start cascade testing in the mid-teenage years and introduce colonoscopy about that time, with the search for duodenal adenomas. So bowel cancer is about 100% incidence in FAP over a lifetime, typically by the age of 45. Duodenal cancers is about 8% over a lifetime. And you can see some other cancers, including thyroid, which we look for regularly, and adrenal tumours are common, though benign. An autosomal recessive condition is similar, MUT-YH-associated polyposis, and managed in much the same way, so I'm not going to dwell on that. So recessive, it's a base excision repair gene which is not functioning, and when both copies are not functioning in the germline, then the capacity to excise faulty bases is not there, leading to specific somatic mutations in the APC gene, which drives the formation of adenomas. And as I say, the surveillance is very similar to what we see in FAP. So here's something, I'll just pause 10 seconds. Anybody know what that is? I'll give you 5 seconds. So this is the perioral pigmentation and buccal mucosal pigmentation characteristic of Peutz-Jeghers syndrome, which is a hematomatous polyposis syndrome where polyps occur from the stomach right through the colon, and in particular also in the small bowel, where they can be very troublesome. Its incidence is much less than the other ones we've been talking about. We know the gene that causes it. It does have a range of malignance risks, which we didn't used to think of 20 years ago, but we now know is there: colon, pancreas, hepatobiliary and breast and cervix, and funding gland polyposis. And the management there, we have to remove the polyps, including in childhood, because of the probability of interception from small bowel polyps, and clearing the polyps and surveilling the patients for their breast GI cancer risk and hepatobiliary risk, including endoscopic ultrasound and magnetic resonance imaging for the relevant risks there. Video capsule endoscopy has a place in these patients as well. Juvenile polyposis, similar. Hematomatous polyposis syndrome, a much rarer syndrome. 2 genes responsible. The one that's of sort of interest is SMAD4, because it's also associated with Osler syndrome or hereditary hemangiotelic The SMAD4 ones get small bowel and gastric polyps. The other one, BMPR1A, is usually just colonic, but it's autosomal dominant as well. A variant of that is Cowden syndrome, and here you can see the tricholemas of Cowden syndrome that you can see as little papules on the face and inside the mouth and cheeks. So the last polyposis syndrome is serrated polyposis syndrome, the newest on the block, but the most common, where there is a host of serrated polyps that occur either in one of two forms or both the forms, where there's 5 larger serrated polyps above the rectum, usually in the right colon, or 20 of any size spread around the colon. Those are the 2 criteria, of which only need to reach 1 to make the diagnosis. The problem here is it's the only polyposis syndrome we haven't got an identified germline mutation for. It does have a cancer risk of about 4 to 5-fold, and there's also a similar risk in relatives of about 4 to 5-fold, although they don't seem to get the serrated polyposis. Only about 8% of the relatives get the same serrated polyposis syndrome, but they get the same bowel cancer risk. So they need to undertake colonoscopic surveillance every 5 years from the age of 35. That's the relatives, first-degree relatives, whereas we need to keep the polyps under control with colonoscopies every 1 to 2 years in the affected individual. So the second last slide is the Australian guidelines. You all know about the National Bowel Cancer Screening Program, now starting at 45, 50 invited by the government, 45 by application from general practice or indeed individuals from 45 to 50-year-old people for the kit. And then the range of risks from moderate to severe risk, attracting colonoscopic surveillance. People who've got a relative aged 60 or under with bowel cancer, first-degree relatives, are offered colonoscopy from the age of 50 or 10 years younger than the age of onset of that cancer. And then with the accumulation of more features, there is the need to consider referral to a familial cancer clinic and more frequent colonoscopies in the high-risk group there, 3. The number of polyps that we take in order to introduce genetic testing in polyposis conditions is really quite small. If you've got only 10 adenomas under the age of 50, that will attract a recommendation for germline testing. And if you've got 20 or more at any age, then that would also recommend itself to germline testing for a polyposis condition. So when to refer to a familial cancer clinic, the multiple polyp scenario that I just mentioned, serrated polyposis, 3 or more juvenile polyps, multiple Poitz-Jaeger polyps, multiple adenomas and endometrial cancer, and sometimes a mixed phenotype we're happy to accept to explore. So I'd like to finally just point out some references that might be useful to you, and once again acknowledge the wonderful work and support for this webinar from the Cancer Council of Victoria. Thank you.